I'd like to introduce Mike and Caitlin and have them kind of just give a day in the life of what you're doing at Uber and then maybe onto their mission and vision.
Sure.
Caitlin.
Hi everyone, so my name's Caitlin Donovan and I'm the Global Head of Health at Uber. Like Kate said, I think our missions are very aligned where we're working on how do you solve for some of the health equity issues that you see, but in a very scalable way by tapping into existing ancillary benefit structures and making them more efficient, more usable, and more patient-friendly.
Mike?
Great. I'm Mike Cantor, Chief Medical Officer for Uber Health. I'm a geriatrician and lawyer by background, and I work with the team to support them on clinical strategy in terms of product development. Also think about go-to-market strategy and business development support. And to me, what really matters about what Uber does is we help to move people to healthcare, and we help to move things to people. So in some cases, we're actually bringing people, really I think, and we'd heard this just before lunch, the whole idea now is that instead of bringing the patient to the care, you bring the care to the patient. So Uber can either bring you to your doctor's visit, or Uber can drop off a prescription, or Uber can bring your home health aid. So those are the kinds of things that I think are really promising, is the ability to tie the system together and to also make it much more easy for people to access healthcare related services when they need it. So that's what's most exciting to me about working with Uber.
Thank you. So, Caitlin, you just kind of mentioned that you've kind of recognized the infrastructure that is already in place in healthcare and how in order to sort of innovate and transform within it, you kind of have to acknowledge that and work. So what are some examples that you're doing right now within the system, working with patients and partnering with health systems?
Yeah. So I think we partner, like Mike said, we're trying to do our best to stitch the ecosystem together. I think that's been a common theme throughout this conference. So we have a very large mix of types of customers. We work directly with health systems. We work with home health nursing groups to bring nurses into the home, as well as working with payers directly and the specialty benefit managers that are taking on value-based risk. And to your question, Kate, I think to see what we're doing, I think it's important to hear some examples of what's gone really wrong with our customers when they've set up programs with the best of intent. So want to give a real example that happened to a patient. This patient had chronic kidney disease. They were a dual eligible member that lived in Kentucky and regularly went to therapy in Cincinnati in Ohio, so had to cross state lines. They were part of a program that was a value-based program where they had a care coordinator. And what happened was we were contracted with their care coordination company. The idea being incentives are aligned. They're getting upside and downside risk. They should be incentivized to pay the extra, $40 for a ride to get that patient to care. But here's what actually happened. That patient needed care. They were about to have an acute event. They had exhausted their benefit because Medicaid wouldn't pay for the benefit because they were crossing state lines. Medicare wouldn't pay for the benefit because that had happened too many times. And then the care coordinator that had every incentive in the world, it's the right thing to do for the patient, they're financially motivated to do so, they're contracted with Uber with the intention of doing so, didn't take the action because the benefit had been exhausted, right? So what happened is patient had an acute event, an ambulance was called, so now just the cost of transportation alone was thousands of dollars, not $40, and the patient had a hospital stay. So that to me is an example of where everything is going wrong. Even when you have a technology, you have a network, you have a system with the best intent. So what we're doing a lot is not just saying, here's our technology, good luck, but really talking with all of the ecosystem players about how do you prevent that in the future? How do you design your benefit? How do you design your value-based payment to incorporate all of these ancillary benefits like transportation, like food, where there's an existing mechanism for that? And how do you pre-plan for what happens in the case of benefit exhaustion, which is where Mike comes in quite a bit to pre-plan for what's clinically appropriate.
Do you want to speak to some of that in the work that you're doing? I have lots of questions, and I'm going to come up with some more about continuation of care. And also, by the way, very open to have questions from the audience. So I'm going to probably ask one more, and then we'll look to others if they have some input. But Mike, did you want to give some other examples or where you come in those situations that Caitlin just mentioned?
Absolutely. So today, Uber Health offers rideshare. And rideshare is curb to curb. So you have to be able to get to the car at the curb, and then when you get to your destination, go from the car into the building to your appointment, and then reverse on the way back. And that doesn't work for everybody. Some people need help to get from their building, to the car from the building, and vice versa. Some people need to take a wheelchair accessible van. Some people need to access ambulances because they have to lay flat or whatever it might be. And so we're now developing the programs that are going to bring all this into one place. Because today, if you're working in a busy clinic, and Uber Health, by the way, has an app basically that faces the clinicians. So you don't need to have, if you're a patient, you don't need to have a cell phone or smartphone. You don't need to have a credit card. You don't need to have an Uber account. It's all organized from the clinic by the people working in the clinic, and that's where the true clinical interface occurs. So how do you make sure that they know what they need to do to use the app? It's pretty straightforward. We're all familiar with it. The beauty of it too is that if you're in a busy clinic, there's always this issue with people showing up late. And it's not just the doctors, right? It's sometimes patients show up late. Because Uber, the app that we use for health, is pretty similar to what you use that we're all familiar with, you can actually see where the patient is when they're on that trip. So you'll be able to know that they're stuck in traffic, or that they missed, didn't connect with the driver and we had to send someone else, or whatever happened. In real time, you can actually use that clinically to make sure the patient's coming in and that their clinicians are ready to get to them in their appointment when they arrive. And so it's thinking through things like, if we're going to offer a service that helps people get door to door, so what kinds of training do we need for the drivers? How do we make sure that certain kinds of patients probably shouldn't be transported even if they are technically able to get to the car? So people who are really sick, for example, our drivers need to know, hey, there are limits, and there are certain kinds of patients. We're just not set up to safely transport. You need a wheelchair accessible van, or you need other kinds of higher level transportation. So that's really where we've done a lot of work, is thinking through those kinds of things. And then the next phase, the vision, is sort of a one-stop shop for healthcare related services. So it's sort of like Uber Eats for healthcare. So instead of just having the ride app, you can have prescription delivery, grocery delivery. Maybe you have a telehealth visit by clicking on a button there. Maybe you want to order a walker, wheelchair, whatever. You can get your durable medical equipment through that. And we can see where, by using Uber as a platform, we can begin to bring in all kinds of different health services and work with a health plan so that there's an eligibility feed. So that person who's going online to buy not just their ride, but now they're going to get their prescription delivered, they know how many rides they have left that are covered by the plan or not covered by the plan. And through that integration, we're actually able to make it easier, simpler, not just to do the organization, but to see what's being set up. Because one of the other challenges is, how do you know that this ride has been booked but not the prescription delivery? Well, if there's a one-stop shop, it makes it pretty easy to track and report out and to measure and to monitor over time.
So part of my day job is spending time talking to CEOs of health systems, and sometimes they're safety net organizations, right? And they're really worried about how they're going to get this paid for. And one of the things that you mentioned came up literally in a conversation this week. I was talking to a CEO, and they said, working with Uber, it turned out, we've cracked some of the things that the patient's not turning up. But then we're also thinking about, we have to provide the additional person to make sure that they're there to receive it when the Uber driver turns up. So tell us what happens next. And I think you've kind of touched on it a little bit. What are additional plans that Uber might be thinking of to work directly with the health systems to sort of continue that care? And we're just outside over lunch talking about preparation for procedures, and that experience can actually start in the car.
I think that's exactly right. So just like Mike was saying, there's a good reason to have a one-stop shop for patients. When you've been diagnosed with an illness or you're maintaining your care, that is emotionally really tricky already. And then to be given homework, whether it's by your health plan or your provider, really just sets the patient up for failure. So when I think about sort of the things outside of the four walls of a hospital that a patient might need, whether that's transportation or food or their prescriptions delivered or over-the-counter medications, right now the patient has to go to 10 plus places to coordinate that care. And so that's really the value of the provider-facing and patient-facing hub that allows them to organize that. That said, just having that is not enough, to your point, Kate.
Yeah.
You need to know, as a patient, how do I prepare? How is this available to me? What do I do? And we found some really interesting data at Uber generally. I'm sure most of you have taken Uber rides, and I know I always find myself looking at my phone because I'm bored in the car, right? So I'm looking there, I am highly engaged with whatever is on my phone, and our data suggests that you get about 2 minutes of dedicated engagement time while someone is in an Uber ride. I think that is incredibly valuable to a provider, to a health plan, to a care coordinator that is responsible for the outcome of that patient. What's really cool about Uber Health, like Mike said, we don't operate on the Uber app. We connect with patients via landline phone call and secure text message. So we already have the patient's phone number. We already have a dedicated audience, and we have the ability to deliver information at the whim of whatever the hospital needs, whatever the provider needs, whatever the care coordinator needs, to successfully run that program for the patient. And so we're definitely exploring that now. Again, our whole goal, I think technology is really powerful, but it loses its efficacy if you just throw it over the wall without thinking about the operational flow behind it. And so that's where we're spending a lot of our time, is how do we take this to the logical extreme to really impact both patient care and ease the administrative burden on providers, because more and more just keeps getting added to them.
Yeah, not only can you push information out to someone in the car, you can ask them questions. And so more and more health systems and physicians are being graded, literally graded, on patient experience, which is fantastic. But it also means it's very high stakes. And so there's a lot of great opportunity here to take advantage of those 2 minutes of time, which sounds like a short time, but actually if you're only asking a few questions by text message, that can be done in less than a minute. And so it's really a simple way to engage patients who have just left the patient experience, to ask them, how was it, what can we do better, and to help them create sort of what we call CAPS, the Consumer Assessment of Health Plans and Services, to be able to do that in a simplistic, more straightforward way while we have a captive audience, literally, in the back of a car. The other thing that we can do is look at specific conditions and begin to create special programs for those conditions. So if a health system is struggling with its dialysis transportation, we certainly can help with that. We did a project in Washington, D.C. with 2 federally qualified community health centers where we had identified in the Washington, D.C. metro area where women were having to travel more than an hour by public transportation, yes, within the city of Washington, to these clinics for prenatal care. And so we created this Rides for Mom program where basically Uber took the place of public transportation, saving, I think on average, like half an hour out of an hour-long journey, which is a long time if you're trying to juggle your job and kids and then you have to go see the doctor. And we saw very impressive uptake. The patients, I think 75% of the time, decided to rely on Uber. They said that if they didn't have Uber, I think 70% of the time they said they probably would have missed 1 or more visits. And so this is how, like, stitching something together, not just generically helping people get rides to and from hospitals, but actually focusing on specific patient populations can actually directly deliver results.
Great.
So I don't want to forget now, I want to ask you a question about workforce, and then I also want to ask you a question about stitching together people's plans. But before I go on to that, are there any questions in the audience that people might have for Caitlin or Mike around the work that's going on at Uber? Super happy to put them forward before I move on with mine. Okay, you can give it another minute. The question around workforce is, apart from making sure that patients turn up for their visits, it's does the nursing assistant turn up? Does the community health worker get out to where they need to be? And if the community health worker doesn't get there, then you've got a whole other set of problems that you're going to have to deal with. What are some of the experiences that you've had, both in an urban and maybe even a potentially a rural environment in those areas?
That is a great question. We actually just announced a partnership along this front because it's so prevalent in need. What we're finding is for nurses, community health workers, assistants, often transportation is a barrier for them as well. And even if it's not, there's inefficiencies to using a car versus an Uber, especially in an urban environment. You're driving around looking for parking. You have to park. You're paying for the parking. You might get a parking ticket. You pay for that. And so what we've found is, especially where there's a labor shortage, taking care of our caregivers makes a big difference in helping with the recruiting funnel and helping with the administrative efficiency of managing that recruiting funnel, and allows you to see in an urban area, anecdotally, we've heard from our customers, it's about an extra patient a day, which really matters when there's been a labor shortage. We also think about, again, how do you take that to its extreme, where I think it's important, if you're a patient, to be able to manage your full day. You need to know when things are coming, right? It's not good enough for a patient experience to say, you have an appointment sometime today, I hope you stay home and do nothing else. That is a terrible experience for a patient. And so just the value of being able to track where your nurse is, where your community health worker is, not only is it beneficial for that caregiving group, it's really beneficial for the patient too, because you now know this person is on their way, I can see their Uber moving, they'll be here in 30 minutes, or they haven't left yet, I have time to run an errand. So that's how we're thinking about it. And I think last week we announced a partnership with ShiftMed, for example, that staffs with hospitals and uses Uber exclusively to get their nurses to the hospitals because they found such a positive ROI.
I did not know that, so that wasn't a planted question. I wanted to go back to the point you made about the maternal health. So Dr. Cheryl Whitaker, she's kind of like a thought leader in health and equity on the south side of Chicago, and she told me an example one day of how there was a particular woman that needed additional screening, but because of her insurance, it meant she had to go past 3 hospitals that could have done the screening to get to the one that was actually going to enable it, but she had 3 kids at home, too much going on, didn't happen, things did not go well. So what I'm curious to understand, and we were talking about this again outside, that there is a big difference between the symptoms and then the root cause of the inefficiency. So when it specifically comes to working with health insurance plans, are there other examples you can talk to about how you've kind of said, okay, this is going to work, or we'll work with you to manage this?
Yes. So especially for underprivileged communities, so Rides for Moms is a great example. If this mom was on Medicaid in Chicago, would be another example. Medicaid transportation is always a covered benefit, but there's 2 major inefficiencies in the system that we're seeking to solve, again, in partnership with the overall ecosystem. Number 1, you have to use the lowest cost of service. So in the case of Rides for Moms, that was public transportation that did not work for the mom and was leading to worse clinical outcomes. Similarly, it sounds like in Chicago, you had to go to this in-network hospital. You probably had to take public transportation because that is also a rule in Illinois, led to a bad outcome. The reason for that is it's candidly the way insurance companies pay for transportation. Instead of thinking about this in the continuum of care and incorporating a value-based payment into their other value-based payment mechanisms for the provider, who are well equipped to make the decision, yes, it's going to be cheaper to pay $20 for a ride than have an acute event, or no, this patient can get here, that's not where I want to spend my dollars. They outsource the transportation benefit on a value-based basis to a separate company who's entirely incentivized to suppress transportation utilization, which is not the right model. The way that we think about it is for ancillary benefit spend, like transportation, like food, et cetera, for the marginal dollar, you probably want to spend it. And so it's more appropriate to either have a fee-for-service arrangement with controls or carve that into the value-based payment. And the whole reason that it was not designed that way is candidly because of lack of technology. These networks are incredibly fragmented, hard to design, and so originally without technology, they coupled the network build with the benefit management. What Uber's doing is allowing us to divorce those 2 concepts, so you can have a network built and then use Uber's technology to allow that value-based provider to connect to the network in a way that makes the system run a lot better. So coming back to the Rides for Moms outcomes, these moms were on Medicaid, had a transportation benefit, and just by embedding the technology at the provider and at the point of care, so they could make the decision about which mom received that incremental spend, the results were off the charts good, right? These moms were attending 2 more appointments in their episodic care. And I think that's a really powerful message about how we're working not just with the provider who's executing the action, but with the health plan MCO state that's designing the program to make sure that we're not just addressing the symptom, I can't get to my appointment, but the root cause of why.
Agreed. And I think, first of all, the challenges of transportation and we've already talked about this, it isn't just for the patient to get to the clinic, it's to get the people to the patient. And I make house calls one day a month. I work for a company that works with complex, usually older adults, Medicare Advantage mostly. And I was making house calls earlier this week, and I had to park in Cambridge. I don't know if anyone here has ever tried that, but this is not for the faint of heart. Luckily, it was on Sunday, so I didn't have to worry about most of the permit parking rules. Otherwise, I probably would have had to park in Somerville and commute over or something. But this is a serious challenge for anyone who's trying to just get from point A to point B in certain parts of our country. And this is something that personally, and the other thing is, I just had to call them and tell them when I was coming. So I'm already, of course, being the doctor that I am, running late and saying I'm going to be there in 20 minutes. And I get there in 20 minutes, but then it takes me another 15 minutes to park. That doesn't look good for me, and now I'm way behind, and it's getting later in the day, and the poor patient's wondering, you told me to be here in 20 minutes, where are you? So again, technology, like if I could just ping, you can text the driver, right, and let them know where you are, they're running late, or they'll text you, where are you? If I could have just done that and said, I'll be there, I'm parking now, I'm right outside your building here, that's an opportunity that we need to do more of, and it's not rocket science. That's the other crazy thing about this. We have the technology. It doesn't require massive integrations and complex data, AI or anything like that. It's just simple communication that we really need to keep focusing on. And it's just a personally relevant example for me about how things could be way better with a different approach. The other thing I would say is that we really value data to prove what we do and to prove its value. So we did the Rides for Moms program. We actually set it up as a study. We're collaborating with a health plan now to focus on a similar maternal program in terms of integrating transportation into the benefits for their members so that when that person is identified as being pregnant, they're enrolled in this program and given this opportunity right up front as part of the health plan collaborating with the health system so that we're all literally on the same page and helping those pregnant people get to care when they need it so they can have healthy babies. And so we also partnered with MGH. We have a partnership that we're working on looking at home health, transporting home health workers for people with dementia and understanding the impact of that on the families and on the person with dementia themselves. So to the extent that some things are not complicated and data-driven and require a lot of data integration, we still really want to focus on proving the value of what we do and finding the best way to use the scarce resources that we have to make sure we're having the greatest impact.
Agreed.
So talking of scarce resources, I did get the finger movement that I've got 2 minutes left.
I have a question.
And Drew has a question. So let's go to Drew's question. Then I have a question about scalability and workforce of the future.
Awesome. So sorry for commandeering. But in terms of data, obviously being a tech-forward company, how are you leveraging the data? So someone gets a ride maybe during the pandemic and you really solved a great problem for them. How are you leveraging the data after all of these great things that you do for people? And say 6 months later, maybe it's a woman who's pregnant, and it's maybe at this point she's given. Do you have the AI and to say, hey, do you need a lift now? 3 months later or 4 months later. But how are you leveraging the data in terms of after someone engages, and then over the course of that relationship with them?
So we actually do that in partnership with our health plans and provider partners versus having Uber do it ourselves for a couple reasons. One is just really care about patient privacy, right? So we're completely HIPAA secure. And I think that we view having Uber be the mechanism to reach out to the patient as a bit of a violation of the patient's trust. But we do work to empower our partners so that they can have a through line of, here's all my members that have this available to them. Here's their utilization. Here's the programs they're in, so that you can have a repeated program to make sure that we're being used effectively. Again, I think Rides for Moms is a great example. I know we keep coming back to this example, but it's quite relevant because you know the episode of care, you know how frequently the mom is there. Coupling that with the data that our providers and health plan partners have, we can measure the impact using a really complete data set as opposed to just, I took a ride one time. I hope that answers the question. Yeah.
David, last question.
Things can happen on a ride if the patient is going to get medical care. It don't happen in a run-of-the-mill Uber ride. Are the drivers especially trained for this, or what do they do if a patient chokes or has a severe attack of pain or throws up? Or
Great question. So for context, before I was at Uber, a couple jobs ago, I was COO of a non-emergency medical transportation benefit manager, which is quite a mouthful. But the way, so this answer is really from my experience there. The way that I think about this is having tiered credentialing standards. I think Mike was saying earlier on, Uber's not appropriate for every patient, and we're quite clear about that. And so the way that we think about our program is, how do we create the appropriate network for you that might use UberX, that might use specially trained drivers, that might use our third-party fleet partners that we have integrated into the system. In my experience, the way to keep the cost down is to match the appropriate level of care with the patient's needs. Rough math, for a Medicaid population, UberX is appropriate about 35% of the time. The remaining 65% needs some form of specialized care. For a Medicare population, especially as folks age into Medicare, that's very different. It's actually more like 80% are appropriate for a curb-to-curb UberX ride, and 20% need specialized care. And then for a commercial population, we're actually seeing data that suggests that large employers sometimes have subpopulations that look like a Medicaid population, especially in manufacturing, retail, and call center environments. And there, the level of acuity is lower, and so Uber tends to be appropriate more like 95+% of the time. But we work with our partners to structure their networks to solve for that problem.
Thank you. We are at the end of our time, and I might get dragged off if I don't end it now. So thank you so much, Caitlin and Mike.
Thank you so much for having us, Kate.
Thank you.
Yeah, this is great.
Appreciate it.